Well, good evening, everyone. I wanted to welcome you to the San Mateo County Dental Society Member Symposium. It looks like we have a great audience joining us tonight. My name is Ben Yount, and I am your SMCDS president. Before we get started, I want to review how we'll be running this meeting. All participants will be placed on hold. Our presenters will provide presentations on minimizing extractions in surgery, today's orthodontic options with Dr. Alexa Alborzi, and implant-supported prosthesis with Dr. James Mahooti. During the presentation, you may post a question in the question and answer box. For those participants on your desktop, the question and answer box is located on the bottom of your screen. For those on an iPad or iPhone, the question and answer box should be on the upper right. Please feel free to post your questions, and if time permits, we will go over them at the end. So now, let's get started. We're pleased to have two very experienced presenters with us tonight. Our first presenter is Dr. Alexa Alborzi. Dr. Alborzi earned her degree in dentistry from the University of California, San Francisco. She continued an additional 3 years of training and earned her orthodontic certificate and master's degree in dental sciences at the University of Connecticut, one of the top ortho programs in the country. Dr. Alborzi is a speaker, a teacher, an author, a community leader, a San Mateo and Half Moon Bay orthodontist. She founded Alborzi Orthodontics in 1996, and she's successfully enriched the lives of many. Dr. Alborzi is known to tackle some of orthodontics' most difficult cases, not only with a high degree of success, but also minimizing surgery. So without further ado, please welcome Dr. Alborzi.
Here we go. Unmute myself. Hello, everyone. Thank you for attending this event, and sorry for Alexa's interruption. So this is interesting. I've never talked to myself in a screen and not looking at my audience. So this is a new experience for me, and I hope it'll all turn out as nice as we can have it. So here I go. I'm going to share my screen and see the video presentation. I'm just double checking with Ben. Am I being heard okay?
Yeah, you sound great.
Okay, excellent. Let me see what's happening with share screen. Just tested this, so it should work. Except now, it's not letting me see my presentation. There we go. Here we go. We're good on the screen, right? Excellent. So what I wanted to talk today about is how we can minimize extractions and surgery. And the reason I picked this topic was about 18 years ago, I came across new technologies in orthodontics, and I got really excited about practice of orthodontics. And as I started utilize them, I just could not have been happier. And it allowed me to have consistent outcomes, more patient comfort, and better results altogether. And I had been already at doing orthodontics for about 10 years when I came across that. So this is why I'm so excited about this topic. Now, I don't know why my slide is not changing. Let's see. There we go. So some of the common reasons for extraction have been the sacred intercanine width, which has been known like you cannot change the intercanine width, therefore you cannot widen arches, etc. Another reason has been that the teeth are too big for the arch, the existing arch of the patient. Another reason has been lip incompetence. This is probably the only one I'm really in agreement with, because if the patient can close their lips over their dentition, then it's not an ideal situation for facial harmony. And then the other reason for extraction has been camouflage of class 1 camouflage to class 1 from class 2 or class 3 malocclusion. So for many, many years, the extractions have been done successfully. And what's the problem with that? People have had extraction, they're doing well, they had beautiful smiles. Well, there is a problem with that. If you look at the aging population that have had 4 bicuspid extractions, we see that they've lost lip support. They have early aging because they get these dark smile lines around their lips. And we see narrow arches when they smile. We see dark corridors of smile. We see impingement on the tongue space. And we see airway issues. Airway issues have come to light probably in the last 10, 15 years. And really, you don't want to impinge on the tongue space, which in turn impinges on the airway. And also, we've seen with these extraction cases often have significant amount of root resorption. So these are the reasons for me, good enough for me not to want to extract if I can avoid it. So like I said, about 18 years ago, I came across Dr. Damon's discoveries. He came up with the bioadaptive therapy, which is the hallmark of this non-extraction approach. And he said that most extractions are done to make space to eliminate crowding. But what about the face, the roots of the teeth, and the soft tissue? With the Damon system, we use light forces to convert crowding into posterior arch width, yielding ideal tooth position and better facial aesthetics. There is also a growing body of evidence that this approach yields less root resorption and a far better soft tissue response. So I went to his office because by 10 years into practice and going to meetings and all that, I had become a little bit of a skeptic about people saying things. So I went to his practice, got trained, saw what he does, and just seeing these consistent results that he showed just really got me excited and came back to my practice and 100% implemented exactly what he taught in that meeting. And to this day, I'm grateful that I did that. So let's understand the periodontal ligament and why light forces are really important. Well, here's a type of X-ray modeling of the capillaries entering the foramina and of the cortical bone. We see that there is not much room for them not to easily get impinged, right? So if the forces are light, these stay nicely open and blood flows. So as we said, there has been thought about light forces, and Dr. Profit, which is one of the leading orthodontists for many years and the professor in orthodontics, he said that optimum force levels for orthodontic tooth movement should be just high enough to stimulate cellular activity without completely occluding blood vessels in the periodontal ligament. What about the heavy forces? Well, the heavy forces, if the applied force is great enough to totally occlude blood vessels and cut off the blood supply, a hyalinized avascular necrotic area is formed. This area must revascularize before teeth start to move. Well, let's see how that is. Here we go. That's the view of the hyalinized necrotic PDL. This is when we used to say, why teeth stop moving when you keep putting higher and higher forces? I saw that repeatedly in practice. Like the more difficult the case was and the more force you put, the less the teeth moved. And often what the orthodontists would do, they go, okay, let's take a break. Let's take all the wires off. Let's just let teeth relax. Well, what were they doing? They were allowing the blood flow to come back into the periodontal ligament and get things come back to life. Here's the difference. So you see the hyalinized periodontal ligament, and we see the non-hyalinized with vascular PDL. So much more alive here than here. So which one is better for tooth movement, where there's more blood flow and cellular activity? Of course, the teeth move much better. So light continuous forces ensure more effective tooth movement in areas with cortical bone or bone with few narrow spaces. Use forces that do not interrupt vascular supply. That was what Dr. Rice said that. So this is amazing because we often thought, oh, we moved the teeth, so we're going to lose the bone in front of the tooth. But no, when you are vascularized, the bone and the tooth move together. So what have been in all the years tools that have been available for non-extraction approach? This is not the first time somebody wanted to do non-extraction. So the number one tool for non-extraction has been the expanders, RPE, which is very high forces. Why? Because they have to break the suture of the face. Then we use headgears, high to medium forces. And I came across self-ligating braces, and the Damon is the one that I have used. And to this day, I've used many different types of self-ligation braces. There's been quite a large number of companies making them after Damon, but I still love my Damon braces. They're beautiful. Here they are. So this is a picture of the Damon brace on your right. And here's what it looks like. They're very small, very aesthetic. And here's the picture of the twin brackets. It's not about the aesthetic point of it in this talk, but the point is that these rubber bands that we put around these twin brackets create a lot of friction. And the Damon braces have no friction because there's a gate that opens and the wire is free to slide, okay? So the friction is completely eliminated. And by eliminating friction, we reduce the forces by 600 times. Yes, it is 600 times less force. So the pain also changes. It goes, when I describe it, the pain goes from 10 to practically 1 or 2. I used to call patients routinely when I used the twin brackets and find out that they needed some kind of a pain medication after adjustments. With Damon braces, I would call and say, how are you doing? No, they're fine. Or they say, oh, I had to give them Tylenol. And I said, did you ask if it was hurting until they bit down? And they go, ask their child, and then they go, oh no, it's fine. They're not hurting when they don't touch them. So it's quite a bit of a different in force level difference between the self-ligating versus the traditional braces. Also, another big factor in this low force has been the wire technologies. Thanks to NASA, they came up with the nitinol wire, and these nitinol wires have memory. They have very low forces. So this low force will continually work on the teeth over a longer period of time, therefore not requiring frequent adjustment and high forces on the teeth. So we keep the force level low. So much more biological, optimal force levels. So what is the logic behind this non-extraction? So one of the biggest points is the facial harmony. The next thing for me is the airway. I had been doing this type of a treatment for a long time before the airway became actually a known topic. And I just got delighted that I always did orthodontics pro airway. So I was super excited about that. So look at this young man. He has a nose, which is nice. He's got a nice, strong chin. And the midface is a bit dished in. And he's super crowded. Let's see his full view. So here is his face, his crowding. The crowding is significant. It was easily simple thing to do to go and say, oh, there's no room for the cuspid, but I'll go take out the bicuspids on each side, and the cuspid will move in there, and now we have uncrowded dentition. Yes, we have crowded dentition. That's about all we have. But we have to keep in mind the face. So here's the change without any extractions from here to here. Amazing. We created space. We widened the alveolus and teeth fit in. So let's look at why. So low forces have one amazing advantage. When you use low forces with this frictionless system, you're using the muscles of the face, specifically orbicularis oris, and that gives enough force to the front teeth to translate the force to a lateral expansion of the teeth. Now, I don't have that slide, unfortunately, added, but we could expand as much as 9 millimeter in an adult and still have ample bone on the buccal surface of the teeth. So here is the young man. You can see how his face is much more supported around his dentition and lips. The corridors here and here are no longer, the corridor is kind of flows very nicely. So that's the beauty of this technique. There was no expander used, no headgear used, and he got nice support. And as he ages now, we don't see, because the cartilage continues to grow, we don't see his nose and chin continuing forward direction, and then his face would be even more imbalanced as an adult. So from here on, I'm going to go through some cases so it kind of brings to light this expansion possibility without any extractions and without any expanders and just utilizing these light forces. So this young lady, mom had been treated by me, and she brought her in and said they want to do reverse headgear, they want to do expanders, and she doesn't want any of that. So she came to me and I treated her. And as you see, the arch form is quite nicely expanded. You can see this is right after removing the braces, nice puffy gums. And she had small lateral incisors where I left spaces next to them, so the tooth size discrepancy can be handled. And also we see the nice lower arch, but she had a nice lower arch to begin with. Here's the change and the facial harmony. So we see the nice flow of the smile. We can call it the 8-tooth smile, if you like, and delighted. None of the treatment went very smoothly, comfortable, and we didn't utilize any high forces. She didn't have to wear headgear. Reverse headgear would have been an option, and she didn't have to have expanders. So this is really a consistent occurrence with these light forces. And that's what I've always loved about this, using this system. So here's a fun one. Well, do we get away with not being able to extract? No, sometimes we have to, because we still have to consider the face and the total amount of room in the mouth and how much can be broad and arches. The other issue, if you see, this is Paulina. Paulina came to me super crowded. You can see, I mean, my God, how many stacks of teeth do we have here? So unfortunately, one of the things that happen is either they don't go to the dentist or the dentist is just waiting for teeth to erupt. So I'm going to give a power. I am going to vest power in the power vested in me. Allow all of you dentists, go ahead and extract primary teeth. If you see in the x-ray, the root is formed 2/3 of the way, or they're stacking, there is no problem on extracting primary teeth. However, if you extract bicuspid primary dentition over bicuspids too early, then that delays eruption of bicuspid. But definitely some of this trouble would have been probably minimized if some primary dentition had been extracted. So I waited for her to go get some primary teeth first extracted, and then once she did that, we could extract the 4 bicuspids, then we extracted the 4 bicuspids and began alignment of her teeth. Super cute girl, always smiling. Thank God that crowding never stopped her from smiling. So we put the Damon braces on, and voila, she went from this little Paulina to this gorgeous young lady with broad arches, and fantastic result that I was very happy with. So this was quite a transformation for her, but we didn't have a choice other than extracting her teeth. Now, at this point, I want to turn the conversation into using this technology and ability to gently expand for phase ones, and why are phase ones so important. So these are the reasons why phase one treatment is important. One is that we can develop the dental alveolus really easily in this young of a child. Palate can be expanded, whether with expanders or without expanders. In this case, you'll see that I didn't use an expander. She has full bilateral crossbite as well. And then the other reason for early treatment is repositioning of the tongue. By once the palate is expanded, then the tongue can reposition itself to the palate. Of course, if there is any airway issues, those things have to be addressed as well. But when the tongue is able to position itself and the palate is wide enough, then the airway development is much better. And we can also allow the forward growth of the mandible. So let's see what happened for her. Here we go. This is the end of her phase one. Look at the beautiful change in the facial balance. I didn't do anything except make room for teeth using light forces and widening her arches. The rest just took care of itself by nature. And this is common repeatedly. The only reason things don't improve is if some underlying problem has not been addressed. Underlying problems could be tongue troughs, blocked nasal passages, large tonsils, and things like that. Otherwise, nature will take care of itself very nicely. So here's the change in her face. You can see what happened. She just grew, but she was able to breathe better, apparently. Because as we expand these arches, even though it's alveolar, we still help with their airway development. And at this point, she's basically ready for phase two. I mean, that was the end of phase one. Then we waited for all the cuspids to come in. And now you can see what minimal amount of crowding is remaining. Now, often parents who are misinformed, they complain like, oh, I don't want to do phase one because I don't want to treat twice, or I don't want to pay twice. And you all know that they don't pay twice because all orthodontists, for some reason, decided that we're not going to charge twice. We're just going to break their treatment into parts and charge less for each part. But what I tell parents who are concerned with that, and it's great because they understand, I go, if you don't do anything, we're going to have a very difficult situation. And one of the difficult situations, one is psychosocial issues, because I see children who have really bad dentition, they stop smiling pretty much. And the other is the situation gets so difficult that they would have to probably extract. This was her x-rays before and after. So I say, you know, if you do phase one, you're spending a lot less money now. And if for some reason when they're a teenager, basically they don't look like this, and they haven't stopped smiling for years up to this point, and they can always, as an adult, I'm gonna go back to her, they can wait till they're an adult to do this treatment. It's not like as a teenager, they have to have this treatment. Well, in her case, actually, the idea was to get her started, and COVID happened, and the parents are teachers, so there it goes. She is waiting to get treatment sometime in the future, and she has a retainer to maintain her in this position. So this is the really important things about phase one, and not everybody needs phase one. 90% of the kids that come and they don't need phase one, we just wait. We just monitor, we extract primary teeth as needed, and then postpone their treatment. So we can see this was a no phase one treatment case that came to me recently. The teeth have erupted in positions that are not really favorable, and she has poor tongue posture. The bite is kind of an open bite situation, and the face is developing not so well. So it behooves us to really direct these parents to really think about considering phase one for the long term. And if it was the cost, really the cost maybe is $1,000 more than the total treatment. And usually people don't balk at that too much. So is self-ligating Damon braces the only solution to this kind of a treatment? And perhaps, but not really, because I was lucky enough to know what I can do with self-ligating Damon braces. And what I did, I translated it into use of plastic, also known as aligner therapy. I use Invisalign for treatment, and I began converting the same approach to treatment to use of Invisalign. But Invisalign also is very light in forces, so the light force therapy continues. So here's an example of a phase one treatment. And we can see that she has a significant overbite, significantly narrow arches, no posterior crossbite in her case, but definitely crowded, poor lip positioning. And I did Invisalign, and I used the type of a mandibular advancement, which I'll share with you later, to help her grow her lower jaw. She did the best that she can with her growth. Not everybody grows mandibles easily, but at least what I did, I forwarded the mandible more than retract the maxilla. Therefore, it helps with her airway, and she has nice, beautiful arches for her tongue. So here's her before. You can see again protruded upper incisors and the nice balanced position of the teeth at this point. And now we're waiting for her to just get all her permanent teeth in. What about the teen? Teen can also be treated with Invisalign. These cases from here on, most of them are Invisalign cases, because once I became proficient at the use of plastic to similarly use it as I would with the Damon braces, there's never a problem with me to tell someone you can be treated with Invisalign. Majority of my patients nowadays come to me and they go, I've been told I cannot get Invisalign. And I said, okay, well, you're not going to be told by me. So I can treat you with Invisalign. So this is a rather difficult case. I would say from a 1 to 10, it's a 15, because there's no posterior contact, anterior crossbite, narrow arches, you name it. So we used Invisalign and created these beautiful arch on the upper arch and the lower arch, and we finished him very nicely. He just actually, I just removed his attachments yesterday, and he was just so super delighted, and he could remember how his teeth were when he started. He even had an asymmetry. What I like about use of Invisalign with asymmetry is because I can truly control the dental position to adapt to the jaw position. It's not always feasible not to do surgery in those cases, but commonly it's very workable. So we got this narrow arch, barely any smile showing to this position. And he also went and got a nice nose job, so everything is very nicely balanced. Here's another teen case where She had a severe overbite. Again, I would not have thought that I could ever treat something like this without the Herbst Appliance or braces. But we set out and we did this with Invisalign, and we handled 9 millimeters of overbite and 100% overjet and 100% overbite to this beautiful result. You can see that she has been used for so long to smile the way she is, because this is late for treating a case like this. She's been very fortunate to not have broken these front teeth up to this point. She mustn't have been a very active child. But look at it, she still kind of does that type of a smile because she's just used to that, but she doesn't really muscularly, doesn't need to because her teeth are in the right position. Here's an adult, super crowded. Again, use of light forces, creating alveolar space from this and this to these nice arch forms. And you can see the arch can be developed very well. And I'm just looking at the time, make sure I don't go over 7:34. So basically, she turned out really well. We created space. There's no extra recession or getting out of the bone. It's just very light forces that do the job. Now, do we ignore the periodontium? Do we ignore if there's recession? No. It's really important to diagnose properly and know that, can you do something like that for this person, or do they have a gingival type that you move the teeth and you're gonna get a major recession. So of course we're gonna take x-rays and check all these things on cases that it appears that that might become the case. And of course she had a gem in her tooth, that's why it became a gem of an outcome. Here's her before and after. You can see how the lip line flows with the upper dentition. She does show some gum, less than she did before, but that is a better situation showing a lot of gum than if we push the teeth out and then she would have a flat lip line. So I like to see the lip curvature follow the smile line. So that's a nicer outcome than if we show no gum. Here's another adult case where I used the combination of pads, and in her case, I had to extract some teeth. She was so late in coming and seeing me that I had to extract this tooth, I had to extract the cuspid that was completely out of the bone, and I had to extract some primary dentition that they were still present. So after all those extractions and initial alignment and some rubber band where we got to this point, and she tells me, I'm done, I'm really happy with my results. And I told her, over my dead body, you're gonna keep going. This is not a stopping point. But she was already happy. And really amazing thing that I noticed, look at the change in her gingiva. This was not gingival surgery. Her gingiva actually improved over these teeth. I just don't know how that happened. But we activate bone, we activate tooth movement, and sometimes growth and changes happen that kind of you get mystified. Maybe somebody knows the answer to that, but it was not surgical. I'll show you the surgical types later. Here is the video. Let's see. No, the video is not playing, but that's fine. We tested this twice. Maybe it's because my pointer is on. Let me get the laser pointer off. Yes, that's why. And we can see that placement of these tabs is really simple. So the reason I placed the tabs was I was concerned that now if she continues to wear class 3 elastics, I will tip these teeth too far back and she starts protruding the roots on the lower gingival. So I wanted to keep the patency of her lower gingival periodontium. So we did the tabs, and up to this point, which was recently, she basically used the tabs to continue bringing the upper arch forward, and we have gotten to this point. So now what I'm going to do is create another set of aligners and actually intrude these lower incisors with utilizing the tabs, and then her posterior occlusion will close up really nicely. So this was a patient that, yes, perhaps she could have had surgery, but look, she wasn't going to get treatment any other way on this. I was able to actually achieve this. There was no way she would have gone and gotten surgical correction done. So I think this is much better. A patient will be much better off, even if the face is not super well balanced. I think she looks good, but let's say some people have the viewpoint that this is not well balanced and the maxilla should have come forward, then I think she's much better off with non-surgery than getting no treatment at all. Here's another adult with class 3 treatment. Again, like I said, facially, absolutely, he's a surgical case. But they find their way to me because they don't want to have surgery. So if I give them an option and I go, do you mind if the face doesn't change, but if you have a correct bite, that's what they want, then I can offer it to them. Of course, with good diagnosis, making sure there's enough bone to do what we need to do. And this was his outcome. I say we because I cannot do this without the patient helping me. And they know from the start that if you want to get an outcome, we got to play as a team and you have to help me get you there. And he did. He was an amazing patient. We achieved a really awesome result. And then he went and got some restorative work done, and now soon he's gonna get his implant. He didn't have room for the implant, and I created that space for him. Now he has adequate space for the implant. He was delighted with his outcome, so was I, because he got a better dentition, better occlusion, no harm done to his gingiva, as you can see. Nothing happened, no recession, everything looks great. Often I see improvement like I showed you in that previous patient. And this is the outcome. Here's another class 3 with asymmetry. This is another, he's very handsome, obviously, but he has significant asymmetry. You can even see the asymmetry in the eyes, you know, the lower jaw grew more on this side and didn't on that, and it's just quite asymmetrical, narrow upper arch, you name it, but good looking, right? And I spent quite a long time talking to him about, hey, you sure, you know, any problems with your face? You gotta know once we do this, there's no going back, because once I move the teeth in a position non-surgically, surgery will be more difficult. Because when we do surgical planning, we actually make the problem exaggerate. So here's his outcome. We corrected it, mandibular midline ended right on. And again, he was an amazing patient. So without his help, I couldn't have gotten him here. So we both were super happy. And here's his final result and smile. And very happy. He is smiling bigger at the end than the beginning. That's why you see more gum and everything. So here's another open bite. Not another open bite, an open bite. This patient came to me with an open bite. I love utilizing Invisalign for closing open bites because it allows me to do posterior intrusion which helps close the anterior. You can see that I didn't change his incisors. I really don't like in these cases to extrude their incisors because it won't look good. So we actually cause the mandible to close up by moving the posterior teeth. Here's another case of an open bite. She is super serious. It was pre-confidence with Invisalign. I would now treat that with Invisalign as well, but this was a combination of Damon braces and a TAD applied to the roof of the mouth. I call this like an internal headgear. So what I'm doing with the TAD is actually pushing the molars into the alveolus, and then the jaw auto-rotates. And this position also allows the maxilla to come forward a bit. So this happened within 8 months. It was pretty rapid. And this is again the before, and this is the final outcome without surgical intervention. And sorry, this is washed out, but the facial profile stays really nice, and the smile's much more balanced. So again, another non-surgical way of treating open bites. Open bites historically have been surgical cases. It's almost impossible to close them with braces. Now, here is the class 2 correction. My class 2 corrections are normally, again, I mentioned earlier at the beginning of the talk that I was so happy when the airway cycle started, thinking, oh my God, I've been always pro-airway without the thought of the airway. So correction of class 2 often occurs with putting headgear on, stop the maxilla from growing, and hope the lower jaw will catch up. Now, the other way is with just rubber bands, or you could have jaw surgery. Now, if you look at her face from the mid-half, mid-upper half, there's no imbalance in the upper jaw, so why put a headgear on and stop the upper jaw growing? So my approach is always to help the lower jaw grow. So I use the Herbst Appliance, and the appliance actually helps grow the lower jaw forward, and you can see in this young lady that the jaw came forward, and we corrected the significant class 2 and overjet. Here's the before and after of the facial balance. And here's what the Herbst Appliance, this style is from molar to molar. It's called M2M, and very convenient and in the back. I can also use this in combination with Invisalign, and I've done it for a few adults who have had jaw problems where bringing the lower jaw forward was a good way of treating their jaw problem. So it's a convenient, non-compliant appliance, and it can also improve the airway with the retruded jaws. So in lieu of all this metal, now Invisalign has the ability to also help reposition the jaw forward. These are wings added to the aligners, which help bring the jaw forward, just like the Herbst Appliance. And you saw earlier, I treated this young girl with that approach. I used the Mandibular Advancement Appliance with Invisalign to bring her jaw forward. Now, class 2 correction, there are different ways. If there's no skeletal imbalance, we have other tools to minimize the number of aligners or amount of time in braces. We can use an appliance called Carrier. It's a bar that goes all the way to the molar and has a swivel that allows the molar to rotate. And they wear a rubber band to a lower aligner or a retainer or a lingual arch, and it helps correct the class 2. So you can see here, she was practically focused class 2, and it got corrected. It usually gets corrected within 4 to 6 months. So it's really nice if they are compliant. Of course, compliance is always the reason for orthodontic treatment taking a long time. So those are all approaches that I take in terms of non-extraction therapy, but some of the cases can be pretty difficult. So I'm always happy to speed treatment. So I've found that acceleration has been very effective. It reduces treatment time. It improves the gingival response. It increases comfort. It also can improve retention. Once you're in retention and you use the vibration appliances such as this V-Pro, then the actual bone development improves. V-Pro is used for 5 minutes, and we have Maxilla, then that's a 20-minute per day appliance, and then the Ortho Pulse, which uses photobiomodulation, is a 15-minute appliance. I've used all three, and I found that the key is compliance again, and 5 minutes is doable. The rest, some do and some don't. I find more compliance with V-Pro, and it has really reduced some treatment cases up to 50%. In most very difficult cases, we really don't go beyond 2 years in treatment. So it keeps the difficult cases in a lower time span. Here's another way of speeding up treatment and actually accomplishing everything that we just talked about. Here's a case where I would not be able to treat just by alveolar expansion, use of light forces. He's just structurally very dolichofacial, very narrow, high palate, and he already showed lots of recession everywhere. So I gave him his options. His options were surgical maxillary expansion or go and get osteogenic orthodontic periodontal treatment. And that's what he did. Basically what that is, it's a flap perforation of the bone and adding bone and then closing the flap. That surgery and the perforation basically causes the alveolus to be more malleable and we can expand. And as you can see, from here to here and to here, we really widen the arch without actual palatal expansion. From here to here, you see that we closed lots of space and expanded the arch within 4 months. This started being done as a name. It was named Wilcodonics, and where they do these palatal surgeries, but they also cut the in between the alveoli to create this. But this one was done with just perforation, and you can see how fast we can actually move the teeth. This is not the end of his treatment, but I'm just showing how fast it can go. Also, the other reason I chose this approach for him was because if he just did expansion, he had a lot of recession. So I found that if he does this procedure, his recession will get handled and he will get the expansion that he needed. And that's exactly what happened. So it was a one-time surgery for him instead of doing surgery twice to get the same result. There are other approaches of acceleration, and one of them, the other one is Micro-Osteo Perforation. This one is done without doing any flaps, and what you do is basically you go through the gingiva and like tabs, you put holes into the interproximal bone, and it causes the teeth to move much faster. And this doctor here, it shows she did this correction in 10 months. This movement was done in 14 months. And these impacted cuspids were brought in within 6 months, utilizing that kind of acceleration. And the reason this acceleration happens is these mechanical interventions just basically increase the osteogenic activity of the bone, and teeth and bone can move much better and speed up the treatment. So I'm almost quite on time. That's awesome. So in summary, what I would like to go over was the fact that the light forces is the key. It's the best biologically sound way of moving the teeth. And self-ligating braces and Invisalign or any other new aligner treatment, which I don't know if they're as effective, but they still allow light forces. But the key with the Invisalign has been all these attachments that we put on the teeth to allow us to really be able to do the same thing as braces. So they can allow light forces, and the alveolar expansion without sutural expansion is possible. Okay, that's been proven to me. I've been doing this for the last 20 years and over without any change in my idea, it occurs. We can use acceleration in treatment to help the patient finish their treatment much more rapidly. It reduces discomfort, so that's how they feel better about it also. And I find that it motivates them even more. And then we can use temporary anchorage devices to avoid surgical intervention. If the patient chooses that they don't want facial changes, then we can use these devices to help give us anchors that we cannot achieve with just braces alone. But the bottom line of all of this is diagnosis, diagnosis, diagnosis. This is not a random act of, let me throw the aligners in and now we have light teeth movement and teeth come together. No, you have to do your diagnosis. I just was giving you an overview of what can be done, but there's a lot more behind the scenes with respect to taking x-rays, symptometrics, and all the other things that we do as orthodontists to decide. And often we need to coordinate with surgeons or general dentists or periodontists to make sure that we really come up with an amazing plan for the patient for the most effective, ideal, and beautiful outcomes. I am about 6 minutes away from the end of my time, but now it's 5 minutes and I'm done. So I'm going to, I had a bunch more slides just in case I didn't talk enough. So I'm gonna unshare my screen and let the MC decide if he wants to let Dr. Mahooti come over. Thank you for your attention. Hopefully we have time to answer any questions. If not, I'm always available, so you just need to call me and we can always talk in person. Great having you all. I don't know who you are, but thank you for being there.
Thank you, Dr. Alborzi. That was a great presentation. Our next presenter is Dr. James Mahooti. Dr. Mahooti graduated from Northwestern University in 1985, where he also taught as a clinical instructor in the Department of Fixed Prosthodontics for 1 year. He worked and owned a private practice from 1986 until 2014. He also worked in a DMO clinic during that time. After the sale of his practice in August of 2014, he has been traveling implant dentist working in multiple locations. He earned advanced surgical and prosthetic implant training degrees at the Misch Institute in 2006 and 2007. His passion in his profession is solving dentureless problems, along with the restoration of both function and aesthetics. Having attended the Dawson Academy of Higher Dental Education, he is quite comfortable with full mouth restorations, both implant and or tooth supported. Welcome, Dr. Mahooti.
Can everybody hear me?
Yes, we can hear you.
Okay, I'm gonna go ahead and share the screen. How's everybody doing? I can't hear anybody anyway. So first of all, I wanted to thank the Dental Society for giving me this opportunity to talk about my passion in life, which is implant dentistry. I'm gonna give you a tiny bit of background. When I sold my practice in 2014, I was kind of retired, but I had opportunities to go around San Diego, work in different offices. But my cousin, Dr. Samahani, owns a big practice here in Pacifica, and he kind of lured me to come up here permanently. And he told me that he's going to feed me a lot of the stuff that I love to do, and he held to his promise. And here I am. I moved here last December permanently, so I'm going to be a lifer in Northern California. So again, thank you for having me. And I wanted to talk about one specific case, but I wanted to introduce the concept of what an all-on implant-supported prosthesis is. If you notice, you hear a lot about all-on 4, all-on 5, all-on 6. I personally don't like to assign a number because that focuses both the patient and the staff members' attention to the number of implants, and somehow they get pulled into, whatever you charge is associated with numbers. Well, nothing can be farthest from the truth. I tell people that whenever you plan on doing stuff like this, you have to look at it as structural engineering. And it is structural engineering. It's nothing less than structural engineering. So whatever you do for a patient, if they have no teeth and you want it to last and be durable, functional, and minimize complications, you have to design it. You have to design it carefully, and you have to design it accurately. And just like what Dr. Alborzi was saying, diagnosis, diagnosis, diagnosis. It goes a long way. So I'm going to start talking about this one case that I started about a year ago, almost right after I moved here permanently. Give me 1 second to start the slideshow. So there's videos in this presentation that I'm going to go through and pause manually to describe what I'm doing, why I'm doing, what I'm doing. And the video is approximately 18 minutes long, but then the rest is just telling the story. So I met this delightful gentleman, 80-year-old male, no medical alerts, no medical conditions, took medication for high blood pressure. He had to be pre-medicated. I think I had to look at the chart. I think he had an artificial or a knee replacement. Other than that, there's no medical alerts. And when people look at the patient's age, when they look at the number 80, it's like a red flag. But when you meet this gentleman, he's the farthest thing from an 80-year-old. I mean, I couldn't believe he's 80. He had a great personality, great sense of humor, about as dry as you can get, which I fully appreciate because I went to British boarding school. Super pleasant personality, great physical condition. I actually kept seeing him in a 24-hour fitness quite regularly. The guy's he's got it all together. So this is what I ran into. This Panorex is actually way before trouble started for him. He had an upper partial anchored to the upper molars, number 2 and number 15. And then the partial actually with zest type anchors snapped into the 3 implants that you see on the screen. So there's tooth number, let's call it 6. This is 9, this is 14. So when he came in, he had some swelling and sensitivity right around the central implant. And when I looked at it, it was quite puffy and swollen and a little bit of exudate coming out. So immediately the chief complaint is, pain and swelling. So the first thing I wanted to do is just relieve that. Got to get the patient comfortable and gain their trust. Once the trouble goes away, then you can focus on what we can do to solve the long-term problem. So let me just fast forward to this number 14 implant was actually had already failed before, and it was removed. Even when I looked at that Panorex that I just shared with you a couple of minutes ago, this particular implant was already gone. So he only had 2 implants. The one that presented with the swelling and pain, and the other one, which was a little bit to the right of that. Now, when I look at this, when I back up and look at this, these 2 arrows, I just drew these to represent the clasps from the partial. This implant was already gone. This one had pain and swelling. This one was okay. There was no apparent problems with this particular implant. Now, the reason I drew these lines is they're at 3 different horizontal levels. So my speculation, and there's no concrete scientific evidence for why I think this particular implant failed, is I feel that even though these snapped into the partial and the clasps were there, during function there was quite a bit of teeter-totter with this one. So that ended up causing that bone loss, and it led to the failure. So let me go back to the radiograph again. I spoke with him briefly about, well, we need to solve this problem once and for all, and I do have a solution for you. Now, if you look on the lower left, you can see this failing root canal. You can see this radiolucency. We did take a 3D image, but this was already restored with an implant, with a single implant. It'll show in a subsequent x-ray of a final phase of the treatment. So my plan was to remove this immediate problem, take this implant out, graft this particular area, give it about 4 months for it to regenerate. And then I talked to him about putting several implants on the upper jaw and have it being restored with a permanent, fixed prosthodontic prosthesis. And immediate question is, well, how much is the cost, and can you guarantee it? And I hear this question quite a bit, and my universal response is, I don't guarantee anything. I guarantee that I will be given this 100% effort to make this work, and I guarantee that I can handle complications. But to guarantee success, and I tell them, any dentist or any dental practitioner that guarantees any of his or her work, you should run from, because it's not an exact science. But I said, your odds are pretty good. I would say 85, 90+% success rate. So he agreed. We ended up taking off that implant, which basically unscrewed by just finger pressure. I managed to graft the area, and this is the final PA. I just took that PA just to have a look at it. This is after about 4 months. So his swelling was gone, and the area had regenerated beautifully. Prior to initiating the treatment that I'm going to talk about, I like to do these cases under general anesthesia. And I talked to him about that. I don't do the anesthesia myself. Obviously, I'm not qualified. We bring in an anesthesiologist. We set it all up just like they do at Clear Choice. And we get the work done. But when I treated this patient for this one particular tooth, I noticed that, I put topical and everything, and I was very gentle, didn't even flinch, didn't even phase him a single bit. I took out the implant, laid the flap, grafted the area, sutured it, and I looked at it 2 weeks later, and it looked like nothing had ever been done there. It healed like it's been 4 months. So I'm like, okay, I don't think you need general anesthesia. We can do this under local. Would you like sedation? He says, no, I'm tough. I can handle it. I'm like, game on, let's do it. So we reduced the fee for him a little bit to make it fair and square. And we went on to get the case done. So the first thing I wanted to do is to do a 3D image and start planning. So this is the video, and I'm gonna start it manually, and I'll stop all along at crucial stages where I think I need to explain stuff. So here we go. A little slow at first, but it just goes through the radiographs, and soon you're gonna see the software that we use to survey the upper jaw. And I'm gonna stop here. If you notice here, there's a pretty wide area from, I would say, maybe first bicuspid, second bicuspid to second bicuspid. And that's plenty to build a full arch prosthesis with a tiny bit of cantilever towards the back. You don't need to go all the way back to the second molars. Really no need for it. I hardly think there was any function back there. So if we give him a first molar occlusion, maybe a smaller first molar than normal, he's going to be perfectly happy, and he will certainly be a lot more functional and happy with this as opposed to a partial denture. And then I talked to him about, and he asked immediately about the posterior teeth. I said, I think you should just do away with those because they're really not functional. They're going to get in the way. They're probably going to trap, plaque and, cause some problems. So you're just better off without it. So he hemmed and hawed for a second, and he said, well, you seem to know what you're doing. Let's do it. So he agreed. So let's move forward. Now, in the previous slide, let me pause right when it gets there. Right here. Now, you look at the remaining implant, it's too far to the buccal. In fact, I think it's broken the buccal plate. No big deal, but look at how much bone there is. This was actually, right after I removed that failed implant. By the time, I didn't think I needed to take another one because I already have the information about the bone dimensions. I know this is filled in. I had confidence in his cells and, the grafts that we use. So this is a slam dunk as far as ease of operation, the amount of bone that you have. You can place 6 implants here in the positions that these dots are in, or somewhere, close by, and you can have a very predictable prosthetic device put on this and have it function marvelously long term. So again, this is the PA of the grafted area. Everything looked good. So when I plan these things, I kind of get a general idea of how much bone there is at what location. This is right around the failed implant. Again, implant a little bit too far to the buccal. So this, I thought about including it in the prosthetic, but it's not a company that I use the product, and I just didn't want to mix and match. So I just thought I'd just do away with this. And there's plenty of bone palatal to it to place another implant and have that be utilized. Now, the only thing that I kind of not look forward to, I just didn't know how cooperative this implant was going to be to remove. Anyway, excuse me. So I just surveyed the rest of the arch, with this software, and you have a capability of going into this library of implants that are virtual implant placement. First, I did some measurements, kind of got an idea what kind of sizes I wanted to use. So I went into I used Zimmer implants. I went into the Zimmer library, picked a specific size, and kind of took a look whether I could fit it, where I wanted to place the implant. This one happens to be a 4.1 millimeter by 13 millimeters. And it looks like it's a winner, plenty of room for it. Next, I went to the contralateral side, and used the same size implant and played with that, and that looked like a little bit close to the sinus, but we could tilt it or maybe move it mesially. So that looks like a winner. And then the rest of them, I just played around with it. Towards the canines, I used a little bit larger diameter, 4.7 millimeters. Didn't really have to, but just thought, why not? So we put two 4.7 by 11.5. When it's a larger diameter, I don't like to go as deep. Don't really need to. You have enough retention and stability and durability. So I did that. And then towards the middle, I used again the 4.1 millimeter implant. Again, 11.5 millimeters. So with these 6 implants, I felt he's going to have plenty of retention and support and durability. And I was completely at peace with this. And like I said, this radiolucency that you see is no longer there. This was the previous 3D image. I just didn't think I should take another one. So it's a go. We have plenty of room to place the implants. Now the next phase is to plan the surgery. So he comes in. I'm going to try to fast forward to the actual surgery videos. So let me pause here for 1 second. At first, let me back up a little bit. You can see the Zest anchor, and it happened to have a ratchet that fitted exactly. So I wanted to see if it would budge by just digital pressure. So I put the attachment in there, and I got my wrench, and lo and behold, it just screwed right out. I'm like, great. First problem is solved. Next, we went in there and laid the flap, and just a vertical incision also to ease the reflection of flap. So I reflected the flap, and as you notice, the occlusal edge is slightly sharp. And I use the guide, a guide that simulates where the teeth are gonna be. And I just wanted to see how much room we have. But first, I wanted to remove the granulation tissue and a buccal of where that socket is, where the previous implant was, just for faster healing. Cleaned everything up. Next, we went on to the second molar areas, pulled the teeth out without any complication. And he's not sedated, he's just local anesthetic, and he's just sitting there, not even phased. Amazing person. When I grow up, if I ever grow up, I want to be just like him. So now we reflect the flap. I like to see, the entire bone. I want to see that my implant is completely surrounded by bone. Next, we put the guide in. So we know where the teeth are going to come. This duplicated his existing denture. Now, from where the teeth are to the occlusal surface of the ridge, I wanted to have about 5 to 6 millimeters of space. That's where the zirconium, the pink zirconium part of the prosthetic is going to go. And I like to have that much room to minimize the fracture potential. So what I do is I use a round burr and just shave one side of it to the level that I want, put the guide back on, and compare it to the other side, just to see if I got enough space. And once I'm happy with that, then I'll duplicate the same thing on the right side. So you'll see the guide coming in a minute. We'll put the guide in. I just showed this for comparison. And here we have a good, I would say about 6 millimeters of space. So the implants go in here, and the zirconium part of the prosthetic, the pink zirconium, is going to be here, and then the teeth are going to be here. And there's plenty of bulk and minimum potential for fracture, if any. So we're happy with this segment, so let's duplicate that. And once we get it to the desired level, then we can start placing our implants. So first, this is eyeballing it. Some of you may ask, do you ever use a guide? I find guides to get in my way. I do a lot better without guides. So I made sure that I'm far enough to the palatal, where the socket is, because that's where the available bone was. So I do this osteotomy, then I use a guide pin and take an x-ray. And as you can see, he's far enough away from the sinus, so we're definitely in a safe zone. Now we can start placing some implants. So I do the one to the extreme right of the patient first, then I go to the contralateral side, do that one, then I can eyeball where I can place the middle implants. And you'll see in a few minutes, they'll be pretty evenly distributed. And then we move on to the next phase of the treatment. And I pretty much never use a handpiece to place the implant. I like to, feel the torque using, hand instruments. And that just gives me a lot more control over, the tightness of the implant. If you're loading it immediately, which we are, we want to have at least 50 Newton centimeters of torque, which I tested with a torque wrench. I just didn't video it. And all the implants that you're going to see subsequently pass that test. So we're doing the left side now, and then we're going to be putting a guide pin in there, taking another x-ray just to check, make sure we're away from the sinus. And here it is. And we're safe. So we go on and continue placement of our implants. So for these corner ones, I used a 4.1 by 13. And then the rest of them were all 11.5 millimeters. And then with this perio probe, this is a little additional verification. I just feel the inside of the socket, making sure that there's no soft tissue. So we're definitely in the safe zone. Verified by the x-ray, by the perio probe. So we're good to go. So we got the 2 corner implants in. Now we concentrate on placing the middle ones. Same thing, I start with a Lindemann drill just to be able to get into the bone. Once you get the initial osteotomy, the rest is easy. Lots of irrigation, and one trick that I learned at the Institute, Mission Institute, is we always chill our saline rinses. We put them in a fridge. So the cooler it is, the less heating of the bone and the higher success rate of implants. So this one is 4.7 by 11.5. Plenty of bulk, plenty of support, plenty of torque. Everything's right on schedule. And I pretty much always place my implants bone level. Tissue level, I just don't relate to it. Some say you're extremist, but I got to stick to my guns. It's worked for 20 years. No need to change. So here, one thing I want you to pay attention to, the color of this bone chip that came out, it's whitish. We're going to get to that in a minute. So that, you know, that whitish color usually represents maybe a little bit too much overheating of the bone. Usually the healthiest way to do this is to, when you do this osteotomy and the bone comes out, it should be somewhat pinkish in color. That's another thing that Carl Misch was adamant about. So I suspect that maybe I've overheated the bone here a little bit. So after that osteotomy, I just kept rinsing it, you know, cooling it, and keeping my fingers crossed. The other areas didn't pose that much of a issue as far as overheating of the bone. So there's 2 more implants that are coming in. And then we're going to get to the prosthetic delivery, which my lab guy was with me and he was helping me out. So after these implants are placed, we take out these colored abutments and we substitute them with what I call capture cylinders. They're serrated on the outside and they have a vent on the inside. So what we do is after we put those on, well, I'm speaking a little bit ahead of myself. Let's wait till we get there. So all 6 implants are placed and they all passed the torque test. And we check the guide and it looks like there's plenty of room. Everything's right on schedule so far. So now we take the colored abutments out and we take these multi-unit abutments in. I don't know if many of you have heard so much about multi-unit abutments. It's basically an interface between the implant and also the final prosthetic. So the advantage of multi-unit abutments is if the implant is slightly tilted, you can get different degrees of tilt with these. You can get 15 degrees, 30 degrees, or straight. So in the middle, we thought that we'd get a 15-degree tilt to tilt them lingually a little bit, but then these are all straight, multi-unit abutments. So I usually torque those to about 20 Newton centimeters. You don't want to torque them too much. Now, the area that the implant was taken out of, we decided to graft it. So this is Puros allograft by Zimmer. I've used this for almost 20 years. Very consistent results with it. We're just filling in the voids. Next, I put a collagen membrane and we move on to suturing. Now, during this entire time, this patient didn't even flinch. No sign of discomfort, nothing. It was just a rock. Amazing patient. So these are the capture cylinders. You can see the serrations. So what we'll end up doing is the denture, we actually made him a new full upper denture. that was clasped to the molars that we ended up taking out. So we used that for, occlusal rim and everything. So we made the denture. Now what we're gonna do is put some bite registration paste in the denture and seat it in the mouth. First, we checked the occlusion, and it looked like it's pretty close. Now there's the bite registration paste. Now the reason we did that is to know exactly where the cylinders are. So we drilled holes in the dentures. Over here, we're putting some segments of rubber dam over these areas, because what we're gonna do is we're gonna seat the denture with the holes in there, and we're gonna shoot acrylic inside the voids and light cure it. And then we're gonna take the denture out, take off the palate and trim the edges. And that's gonna be our interim prosthetic. And the patient is gonna wear that for about 6 months. Instead of filling in the inside of that with composite, which is kind of a drag to take out, we just put some light-bodied impression material in there and filled in the voids with acrylic. This is light-cured pink acrylic that we're injecting in there. We verified that the bite is right on. The acrylic is not cured yet. Once we verify the bite, we cure the acrylic. And there was holes on the inside. This is actually the trimmed product. As you can see, all the flanges are smooth. Everything is convex. The palate is removed, and there's vents for 6 implants that fit right on top of the multi-unit abutments. And the screws are tightened to about 10 to 15 Newton centimeter torque. So this patient had not had fixed teeth in the upper for a good 25 years, so he was pretty stoked. So that's a great start, but we still have a long road ahead of us. So during this time, I pretty much begged him to stay on a super soft diet. Don't chew anything crunchy. Just be sensible with these. You got to give those implants time to heal, to integrate. So checked the occlusion, found a high spot. It's not the greatest intercuspation right now, a little bit of an eyeball, but we just distribute the forces and we'll monitor the patient throughout the next few months. I kept seeing him regularly, once every 2 to 3 weeks. And again, the chambers were filled in with light-bodied impression material. We just fill it in, wipe off the excess, just let it set. And when it comes time to remove this, then it's very easy. You just put an Explorer in there, pull that stuff out and unscrew and get on with life. So first phase, success. He was ecstatic. He was very happy. But there's challenges coming up. So I wanted to show this. Remember when I mentioned before that there was a failing tooth? Now there is an implant there and it's functioning just fine. His entire lower jaw was restored, and he keeps coming in for regular, checkups, some prophy, etc. He's in good shape at the bottom. This is the recently placed implants, and these red lines represent my range of occlusion. So now 4 months goes by, right before COVID time, and I'm getting excited because our initial presentation, which was supposed to be in April, is coming up. And this is right around February, and we're gonna have plenty of time to finish this case. So he comes in, I take off the interim prosthesis, tissue looks fantastic, everything's great. I'm getting excited. I put the open tray impression posts in. I hand tighten them, no problem. But as I put the hex driver in there to make sure it's tightened fully, not too tight, but just make sure it's tightened all the way to the implant level. As soon as I touch these two, he's not comfortable. I'm like, uh-oh, this is not good. So unfortunately, both of these had failed. Now, that's a damper. I was disappointed. I'm sure he was too, but you could never tell by his facial expression. He's just a rock. So when I attended the Mish Institute multiple times, Dr. Mish, rest in peace, he always said, you're gonna run into complications. You will face complications. Complications are inevitable. So when you face these complications, you have to just show confidence that you can handle it. If you show any fear, any disappointment, any hesitation, trouble may begin. And he used to always say, well, first thing you do is take a deep breath, go out, change your underwear, come back. And we used to laugh every single time. He used to say it all the time. Didn't need to do that. I had faced this before. So luckily, he had so much bone. When I took these implants out, he still had a good 2-3 millimeters of bone in the buccal and plenty on the lingual. So I irrigated these areas like crazy with saline, sterile saline, you know, for a good 5-10 minutes just to make sure all the inflammatory tissue is cleaned out. I even used the curette, make sure there's no granulation tissue, and there wasn't. It just, the implants didn't integrate. So what I ended up doing is I decided to put a size higher implant in each one of those sockets without doing any osteotomy. Just grab an implant a size higher and just put it in. And this time I was just gonna bury it, you know, just suture it closed, and then we were gonna talk about what we did with the prosthetic. So for the one on the left, there was already a 4.1 by 13, so I switched it to a 4.7 by 11.5. And here it was a 4.7 already. So then I changed it to a 6 by 10. Now, anybody who does implants, if you tell them you're gonna put a 6 millimeter implant on a central incisor location, they're gonna freak out. But I'm looking at this overall project. I'm looking at the level of bone, and I'm looking at this as an anchoring segment of this whole prosthetic, and I can totally justify it. And on top of that, you buy 4 or 5 months. Patient's already disappointed, and I told him it's a tiny bit of a gamble, but if I can get the implant to engage with, you know, good torque, I'll do it. If not, I'll just throw away the implant and graft it. So he was on ball. We did that, and the implants were rock solid when I placed it. So then I closed, sutured the area. Now the question is, what do we do with the prosthetic? So this just shows all the stuff that I was telling you about. This just happens to be the implants torqued in, 6 by 10, 4.7 by 11.5. And it looked pretty good from the outside. So the cover screws are on. This one was actually a little bit deeper, so I ended up using a healing abutment. And this is the x-ray. Yeah, it doesn't look great on the x-ray, but you know, the angulation of these segments of the implant will totally support the prosthetic. This angulation is perfectly okay. So we gave this about 4 months for it to integrate. Now, the question was, he wanted to wear this whole prosthesis, and I told him this unsupported segment is under a significant amount of pressure. It's not going to last. Let me section it. He promised that he's going to be very, very careful. And I think in the next day or two, he came in and there was this fracture. So I already had a plan for that. Not the best plan, but yet a plan. This is actually 2-3 weeks later. I happened to take this photo later on, but what we had done is I had sectioned this existing prosthesis. I polished this edge. Then I made him a partial, which kind of looks ungodly, but hey, it served a purpose and he was on board with it. He didn't mind. He said, yeah, if it's 4 months, I can deal with it. So we kind of piecemealed it and everything worked out. This is after 4 months. This is the existing capture cylinders within the existing prosthesis. And this is the healing abutment. The multi-unit abutment goes in with a healing abutment on top. I just wanted to give this a little bit more time. By now, they're rock solid. I did the torque test, went up to even 60 Newton centimeters, and it wasn't budging. So thank God, we got past it. So we went ahead and took the impression, open tray impression, send it off to the lab. Lab usually gives us a wax rim with a couple of screws. So you can screw it in and do an accurate jaw relation. This is a verification jig. This is all those open tray impression posts connected together with Duralay acrylic. The purpose of that is just to check to make sure there's no distortion in the impression. There's no room for error. So it has to fit the mouth and the models exactly. So this is the mouth, the verification jig, and the same jig on the model, and it fits like a glove. So I'm like, great. The major challenges are completely out of the way. Now it's time to fly. So I put the wax rim in, tighten the screws. I have my assistant hold the dental floss. For midline, I back off and look at it, then I make a notch in the wax. So vertical dimension, I've used this trick for years. I measure the distance from the eyebrows to the upper lip. Usually use a mirror and use the coloring thing that they use to separate, the cassettes. There is an instrument that goes for like $4.95 that does the same thing, but this is much cheaper and it does the same job. And then I duplicate the same from the floor of the nose to the chin. And if you get those two distances about the same, you get the right vertical dimension. This is the model, and today we happen to get this back. Today, this afternoon, like right around 2 o'clock, I saw him for a try-in. So we put the prosthesis in, and it looks dynamite. Vertical dimension looks about right. And he looked at the teeth. He was very pleased. So we got the green light to go. This is a close-up. The wax rim, just want to point out, when we get the final prosthesis, there's no concavity. There's no flange. I'm going to make sure everything is convex and self-cleansing. This is what it looks like on the model. So as far as how far back they should set teeth, this is one too many bicuspids. I actually wrote on a lab slip, please just do one bicuspid, one molar, or I thought I did, I may not have. But we talked today and we're going to change that to one bicuspid, one molar. So the basic rule that I'm sure most of you are aware of is the distance from the labial aspect of the centrals to the posterior most implant, and you multiply that by 1.5, and this is how far comfortably you can go back with the cantilever. So I don't think I want to go much past that. Once we remove these bicuspids, we should be right on. And I haven't had the final prosthesis yet because just timing didn't work out. So this is what I have, and I would love to have been able to show the final prosthetic, but that's going to be ready in about 2 to 3 weeks. If anybody wants to see it, they can leave emails, and I'll be more than happy to send them to you. And that concludes my slideshow. And again, I want to thank everybody. And what do I do now? End of slide. Stop share.
Yes. Wow, 2 great presentations. Thank you, Dr. Alborzi and Dr. Mahooti.